There's a patient I think about often. 81 years old when I first met him. Retired engineer. Still sharp enough to do crossword puzzles in ink. He walked 2 miles every morning without fail, lived completely on his own, managed his finances, cooked his own meals, drove himself everywhere. He came in for what should have been a completely routine visit. No complaints, no symptoms, just a responsible older adult doing what he had been told to do his whole life. Show up, get checked, stay ahead of things. He left that appointment with a referral. That referral led to another. The second led to a procedure. The procedure had a complication. The complication required monitoring. And 6 months after that first routine visit, this man who had walked 2 miles every morning could not make it from his bedroom to the front door without stopping to rest. The condition that brought him in the first day, it would never have touched him. It was growing too slowly. It would not have caused a single symptom in the years he had left. But the process of finding it, that is what took him apart. I have spent more than 15 years as a cardiothoracic surgeon. I have operated on human hearts. I have performed procedures that genuinely saved lives. I believe in medicine deeply, and that is precisely why what I am about to tell you matters as much as it does. Because I have also stood at bedsides that should never have needed me. I have watched people arrive at surgery who came in healthy. I have seen the look on a family's face when they realized that the thing that diminished their loved one was not the disease. It was the system that was supposed to prevent the disease. This is the conversation that almost never happens in a standard medical appointment. And it is the conversation that every person over 70 deserves to have before agreeing to another test, another scan, another procedure. The logic that drives modern medical screening was built around a specific type of patient. Relatively young, decades of life expectancy ahead. Enough time for an early intervention to pay off across many years of healthy living. When you are 50, that logic is sound. Find something small before it becomes something large. Treat it while treatment is still straightforward. Gain years that would otherwise be lost. The evidence behind that approach for people in their 50s and early 60s is genuinely strong. But somewhere along the way, that same logic got applied to people in their 70s, 80s, and beyond without asking whether it still held. The medical system updated its treatments. It updated its technologies. It did not update the underlying assumptions about who those tools were designed to serve. Here is the uncomfortable truth that very few doctors will sit down and walk you through. Not because they are indifferent, but because the system gives them 15 minutes and a referral pad, and a nuanced conversation about the limits of screening takes considerably longer than either of those allows. The same test that might add 20 years to a 50-year-old's life might add 2 years to an 80-year-old's. And those 2 years may be spent managing the consequences of the treatment, not living the life that made the treatment worth having in the first place. That is not a reason to stop seeing your doctor. It is a reason to walk into every appointment with sharper, more specific questions than most patients think to ask. Let's start with one of the most commonly scheduled procedures for adults over a certain age. A colonoscopy for someone in their 50s or early 60s is a genuinely valuable tool. The data supporting its use in that age group is solid and consistent. It finds precancerous growths early enough to remove them before they progress. And the benefit over a remaining lifespan of several decades is real and measurable. But the biology of colon cancer is important to understand here. It is among the slowest moving malignancies we know of. From the earliest detectable precancerous change to a tumor that poses a serious threat typically takes somewhere between 10 and 15 years, sometimes longer. That timeline has significant implications for someone who is 76 or 78 or 82. If a small, early-stage growth is found today in someone of that age, the realistic probability that this particular growth will cause serious harm within that person's natural remaining lifespan is genuinely low. Finding it does not necessarily help them. It gives them something to worry about. It gives their physician something that the machinery of medicine then feels obligated to manage. And the procedure itself is not without risk for older patients. The preparation required the evening before, the intensive bowel cleansing process, can cause serious dehydration and electrolyte disturbances in an older body. These are not minor inconveniences. In a 78 or 83-year-old, electrolyte imbalances can trigger cardiac events. Then there is the sedation required during the procedure. Older adults metabolize anesthesia differently from younger patients. Cognitive side effects following sedation are more common in this population than most patients are told before they agree to the procedure. Research documents cases of temporary and, in some instances, more lasting cognitive changes following sedation in patients over 70. And there is a real, documented risk of bowel perforation during the colonoscopy itself. In a younger patient, this is serious. In an older, frilier patient, it can be life-threatening. Updated guidance from major cancer organizations now states that colonoscopy after the age of 75 should be an individualized decision, weighed against the person's overall health, realistic life expectancy, and personal preferences. Not automatically scheduled, not reflexively ordered. The question worth asking every single time before agreeing to this procedure is a simple one. If something is found, what are we realistically going to do about it? Because if the honest answer is that aggressive intervention is unlikely given your age and overall health, then the question of why we are doing the procedure in the first place deserves a direct and thoughtful answer. Cancer screening occupies a particularly difficult emotional space in medicine, and I want to acknowledge that before going further. The fear of cancer is not irrational. The instinct to find it early is deeply human and deeply understandable. But 15 years in clinical medicine has taught me something that is hard to say and harder to hear. Finding a cancer and helping a patient are not always the same thing. They feel like the same thing. The system is structured as though they are the same thing. But they're not always the same thing, and the difference matters enormously for people in their 70s and beyond. Consider PSA testing, the blood test used to screen for prostate cancer. In men over 70, this test frequently detects slow-growing cases that produce no symptoms and would not have caused harm within the patient's natural remaining lifespan. These are sometimes described, with blunt clinical honesty, as cancers a patient dies with rather than from. But once that PSA number comes back elevated, the sequence of events that follows is largely automatic. Repeat testing, then a biopsy. The biopsy itself carries real risks, including infection, bleeding, and significant psychological distress. If cancer is confirmed, the pressure to treat becomes enormous from the physician, from the patient's own fear, from the family surrounding them. Surgery, radiation, and hormonal therapy each carry serious side effects. Urinary incontinence, sexual dysfunction, chronic fatigue, bone density loss. For a tumor that was sitting quietly and going nowhere, the treatment can represent a profound reduction in quality of life in exchange for no meaningful extension of it. Major preventive health bodies have recommended against routine PSA screening for men 70 and older specifically for this reason. Not because prostate cancer is unimportant, because the documented harms of detecting it at that age in that population frequently outweigh the documented benefits. Breast cancer screening after 70 involves the same underlying tension. Mammography does find tumors in older women, but a significant proportion of what it finds in this age group consists of slow-growing, hormone-sensitive cases that are highly unlikely to ever spread aggressively. Yet finding them on imaging frequently triggers the standard treatment sequence regardless. Surgery, recovery, radiation, sometimes chemotherapy. I have seen women in their late 70s undergo extensive surgical procedures and months of recovery for tumors that statistically had no realistic chance of causing their death. The surgery itself took months of their life. The recovery limited their independence. The fear that surrounded the entire experience shaped their final years in ways that the tumor never would have. This is not an argument that all breast or prostate cancer after 70 should be left alone. Some cases in this age group are genuinely dangerous and genuinely warrant intervention. What it is an argument for an honest, individualized conversation before any screening is ordered. The question to ask before your next cancer screening is this: if this test finds something, what is the most likely treatment path, actually look like? And what are the realistic risks of that treatment for a person my age with my particular overall health? You may find that the answer shifts how you feel about proceeding. You deserve to have that conversation before the test, not after. Let us talk about cardiac stress testing next, because this is an area where the gap between what the test seems to promise and what the evidence actually shows is particularly striking. The test itself is familiar to many people. You walk on a treadmill while your heart is monitored, where you receive medication that simulates the effect of exercise on your heart. If you're over 70, have no chest pain, no shortness of breath during activity, no dizziness, no symptoms suggesting your heart is struggling, that test may lead you somewhere you genuinely did not need to go. The fundamental problem with cardiac stress testing in older adults who have no symptoms is that the test produces a high rate of false positives in this population. It identifies findings that look concerning on the data but are not actually causing harm and would not cause harm with ordinary management. Once a flag appears, however, the next step is almost invariably a cardiac catheterization, a procedure involving the insertion of a thin, flexible tube into the arteries to examine the heart directly. The risks of this procedure include bleeding at the insertion site, damage to the arterial walls, kidney stress from the contrast material used, and a small but real risk of stroke during the procedure itself. These risks are meaningfully higher in older patients than in younger ones. And here is the finding that should be part of every conversation about cardiac procedures in older adults who are not experiencing symptoms. Multiple large, rigorous studies examining patients with stable coronary artery disease and no active symptoms found that surgical intervention, including stenting and bypass procedures, did not reduce the rate of heart attack or death compared to patients managed with medication alone. For stable, asymptomatic patients, the outcomes were equivalent. Opening the arteries surgically produced the same results as optimizing medications without touching the arteries at all. What this means in practice is that the path that begins with a routine stress test in an asymptomatic older adult can lead through catheterization to a surgical intervention that the evidence does not support as superior to simply taking the right medications and making meaningful lifestyle adjustments. Blood pressure control, cholesterol management, regular physical activity, not smoking. These have decades of evidence behind them and carry none of the procedural risk. Bone density testing opens up a different kind of conversation, one that involves a test that is itself largely harmless, but that reliably triggers a treatment response that is more complicated than it first appears. Hip fractures in adults over 80 are genuinely dangerous. A significant proportion of older adults who sustain a hip fracture experience serious decline in health and independence in the year that follows. The motivation to prevent fractures is not misplaced. The question is whether the standard approach to doing so actually serves the patient. Bone density scans are widely used to measure the strength of bone structure. When results show significant bone loss in an 81-year-old patient, the response is almost automatic, a prescription for a class of medications that works by slowing the normal process of bone tissue breakdown. In the right patient at the right time, these medications can be genuinely helpful. But in very elderly patients, the picture is more complicated. These medications can cause significant gastrointestinal side effects, including serious irritation of the esophagus. Long-term use carries a rare but documented paradoxical risk, a condition in which the thigh bone actually fractures due to the oversuppression of the normal bone remodeling process. A medication prescribed specifically to prevent fractures can, under certain conditions and with long-term use, contribute to causing one. What does the evidence consistently show actually prevents fractures in older adults? Physical strength, balance, the elimination of household fall hazards, grab bars in bathrooms, non-slip surfaces, adequate lighting on stairs. A careful review of all medications for those that cause dizziness or unsteadiness. Adequate vitamin D and protein. These interventions work by preventing the fall that causes the fracture in the first place. A bone density scan will give you a number. That number will almost certainly generate a prescription. What we'll not do is tell your doctor to review whether your blood pressure medication is making you lightheaded when you stand up or whether your bathroom floor is a fall waiting to happen. If a bone density scan is recommended, the follow-up conversation should be centered on fall prevention first. Ask directly, what are we doing to keep me physically strong and safe at home? That is the intervention with the most consistent evidence behind it. There is one more test worth understanding in depth, and it is one that many people have never heard of until their doctor orders it. An ultrasound of the carotid arteries, the blood vessels running along either side of the neck that supply blood to the brain. Imagine this scenario. A 73-year-old patient. No symptoms. No history of dizziness. No weakness on one side of the body. No episodes that might suggest the brain was briefly deprived of blood flow. Feeling completely normal. But a scan is ordered as part of a routine workup, and it reveals significant narrowing on one side. 70% blockage. Suddenly everyone in the room is concerned. A referral to a vascular surgeon follows. A recommendation for surgical correction follows that. What is frequently not communicated with adequate clarity is this. For patients who have no symptoms, no history of neurological events, no signs that the narrowing is causing harm, the evidence supporting surgical intervention is genuinely weak. Multiple major clinical trials have found that the risk of stroke during the procedure designed to correct the blockage is comparable to, or can actually exceed, the annual stroke risk of simply leaving the blockage alone and managing it with appropriate medications. The surgery meant to prevent a stroke carries a procedural risk of causing the stroke it is designed to prevent. And yet carotid artery imaging continues to be ordered routinely in older adults without symptoms, partly from habit, partly because finding a narrowing feels like finding something worth fixing. Responsible medicine, however, means asking whether the finding actually changes what should be done, and by how much. If this scan is suggested and you have no symptoms, ask the question directly and expect a direct answer. What will we do differently if this scan shows a significant narrowing? If the answer points towards surgery, ask for the procedural stroke risk expressed as a percentage, and ask for the annual stroke risk of managing it with medication instead. You deserve both numbers placed side by side before you make a decision. None of what has been described here is an argument for withdrawing from medical care. Please hear that clearly. The point is not fewer doctors, fewer appointments, less engagement with the medical system. The point is different medicine. Medicine whose goals are actually calibrated to what matters most after 70. Because the goals of medicine do change at this stage of life, and the system is remarkably slow to acknowledge that openly. After 70, the most meaningful medical priorities shift away from detecting every possible abnormality and toward preserving the things that make life worth living. Physical function, cognitive sharpness, independence, the ability to move through your own home and your own community without assistance, the ability to think clearly and make your own decisions. Blood pressure management remains critically important at every age because uncontrolled hypertension damages the brain, the heart, and the kidneys in ways that rob people of exactly those qualities. Cholesterol management matters, particularly in people with established cardiovascular disease. Vision checks and hearing evaluations are among the most underappreciated interventions available to older adults. Declining vision is a direct cause of falls. Hearing loss that goes untreated is now connected in multiple studies to significantly accelerated cognitive decline. These simple, low-risk checks have an outsized impact on daily independence and quality of life. Diabetes management remains essential. Vaccinations against influenza, pneumonia, and shingles are evidence-based, low-risk, high-benefit interventions that too many older adults decline out of general vaccine skepticism, without understanding how different their risk profile is from that of a younger person. And perhaps the single most impactful annual conversation available to any older adult is a thorough review of every medication they are currently taking. The accumulation of multiple prescriptions simultaneously is one of the most serious and underappreciated risks for people in this age group. Medications interact. Side effects compound. Prescriptions written by different specialists for different conditions can create combined effects that no individual prescriber intended. Ask your doctor every single year to go through every medication you are taking and justify each one. Ask which ones could be safely reduced or stopped. This is not rejecting medicine. This is practicing it thoughtfully. The hardest part of everything discussed here has nothing to do with biology or clinical evidence. It is the conversation itself. I understand that questioning a recommended test can feel like being a difficult patient. It can feel like refusing care, like being irresponsible about your own health. I want to address that directly because the feeling is real, but the conclusion it leads to is wrong. Asking questions is not the same as refusing care. It is the opposite. It is participating in your own care as an equal rather than a passive recipient of decisions made without your full understanding. When any test or procedure is recommended, ask what exactly we are looking for. Ask what would we do if we find it. Ask what the risk of this procedure is specifically for someone my age with my overall health profile. Age-specific risk is almost never volunteered. You have to ask for it. Ask what happens if we take a watchful approach and monitor rather than intervene immediately. Active monitoring is not giving up. It is a legitimate, evidence-supported strategy that many patients are never offered because the system defaults to action. Ask whether the guidelines behind this recommendation were based on research that actually included people my age, because many clinical guidelines were developed from studies of middle-aged adults and extended upward through assumption rather than evidence. And if you want to understand what your doctor would genuinely recommend if it were their own parents sitting in that chair, ask that too. The answer is often different from the standard recommendation, not because doctors are withholding their best judgment, but because they think differently when the person in the chair is someone whose life they know and value in a specific way. The doctors ordering these tests are not villains. They are working inside a system that rewards action and creates liability around an action that gives them insufficient time for complex conversations, and that was built around younger patients and never fully updated for the population it is now serving. A routine referral takes 30 seconds to write. The conversation about whether that referral actually serves this particular patient takes 15 minutes that the appointment structure frequently does not allow. That is a failure of the system, not of the individual physician. But you can work around it. Bring written questions to every appointment. Ask for a longer appointment if the conversation you need cannot happen in a standard slot. Bring someone who knows you well and can help you advocate in the moment. And if your physician responds to your questions with dismissiveness rather than engagement, that response itself is important information about whether this is the right medical partnership for this stage of your life. You have spent a lifetime trusting medicine to look after you. That trust is warranted. Medicine has done extraordinary things and continues to do them every day. But trust and blind deference are different things. Trust at its best is active. It asks questions. It expects honest answers. It holds the people and institutions it trusts to a standard of genuine transparency. You have earned the right to know exactly what you are agreeing to, exactly what the evidence behind it shows, and exactly what the realistic risks are for someone with your specific body, your specific history, and your specific life. There is a moment that stays with me from dozens of cases over the years. It is the moment just before the first test. The patient is sitting in a waiting room or standing at the reception desk, about to be handed a referral form. They feel fine. They are independent. They are living their life. The cascade has not started yet. The chain of events that will follow has not yet been set in motion. There is still a choice available. That moment is what every one of these conversations is ultimately about. Giving people enough information to make that choice consciously, with full awareness of what may follow from each direction, rather than moving forward by default because no one thought to explain the alternatives. You are not a scan result. You are not a list of findings on a report. You are not a set of numbers to be optimized. You are a person with a life that has history and texture and things in it that matter to you specifically. Every medical recommendation should be measured against that life. What does this test change? What does this intervention actually protect? What does it cost if something goes wrong? These are not obstructionist questions. They're the most medically responsible questions an informed patient can bring into an exam room. Nobody in that room is going to ask them on your behalf. You have to walk in prepared to ask them yourself. More medicine is not automatically better medicine. After 70, the goal of care should not be to locate every possible deviation from a theoretical norm inside your body. The goal should be to keep you strong, clear-minded, physically capable, and living as fully as possible on your own terms. Those two goals are not the same, and treating them as though they are has cost people their independence, their sense of safety in the world, and sometimes their lives. The most important thing medicine can give someone in the later decades of life is not a clean scan. It is more time living well. Keep that distinction clearly in mind every time you sit down across from a doctor and a referral pad. You now have the questions. Walk in and ask them.